Good afternoon, and welcome to our viewers at home. We're wishing everyone a happy World Science Day. My name is Ivan, and to celebrate, we're opening our doors to welcome you all to the Cube, our research and development facility here on the shores of Lake Neuchâtel in the west of Switzerland. Today, we're joined by Dr. Nveed, who's our Manager of Scientific Communication. Nveed, thanks very much for taking the time to join us today.
You're very welcome.
Why have you decided to open your doors to the Cube?
Well, hi to all the viewers at home, and thank you, Ivan, for the introduction. Well, as you said, today is World Science Day, and science has become a really important part of the company for the last 5 to 7 years. And we thought that using World Science Day would be the ideal opportunity to basically tell the world about what we're doing and why we're doing it. As you said, we're here in the R&D facility in Neuchâtel, on the lakes of Neuchâtel. It looks more like the North Sea today, but I guarantee you it is a lake. And yeah, we thought it would be a fantastic opportunity for people to learn about what we're doing.
Okay, and would it be possible to tell our viewers at home a bit more about what the Cube actually is?
Sure, so it's our R&D headquarters. We basically have two R&D sites, here in Neuchâtel and in Singapore. And across the two sites, we have around 400 scientists and engineers, all of whom are doing research into the development and assessment of reduced risk products, or as we call them, RRPs.
Okay, and could you also explain to our audience a little bit about what reduced risk products are and how they work?
Sure. So reduced risk products are essentially products that have the potential to reduce the risk of getting a smoking-related disease. In order for them to be successful, they need to really have two aspects. The first is that they need to have a reduced risk profile. But secondly, and really as important as a reduced risk profile, is that they have to be acceptable alternatives for smokers who don't want to quit. So we need people to really, smokers who don't want to quit, we need them to switch these products. Now, the way in which we try and reduce the risk of the products is by essentially using tobacco at a much lower temperature. We know that with a cigarette, when you light it, the temperatures in a cigarette can get up to around 800, 850 degrees centigrade. And of course, at that temperature, you have a process called combustion, or as we will call it, burning. When you have combustion of any organic material, so whether it's some leaves from a tree or grass from your lawn or tobacco, you basically get in excess of around 7,000 chemicals being formed. And as a smoker, you're inhaling those 7,000 chemicals. And essentially what we're trying to do is we're trying to find ways in which we can still deliver nicotine, like we get from cigarettes, but with less or significantly reduced numbers of harmful, what we call harmful or potentially harmful compounds, which are there because of the combustion process.
Okay, and as such, what would you say is PMI Sciences' mission?
Well, PMI Sciences' mission is essentially to reach the mission of the company. And our company mission is to essentially develop and assess a portfolio of reduced risk products, which are acceptable to current adult smokers who don't want to switch. And the idea is that in the shortest possible time frame, you get all smokers who don't want to quit smoking to switch to one of these reduced risk products.
Okay, and could you explain a little bit more about the type of scientific research that is carried out here at the Cube?
Yeah, sure. So here at the Cube and Singapore, as I said, our other R&D center, we really have a multidisciplinary approach to the way in which we develop and assess these products. The process that we use to assess the products really is something which is very similar to what happens within the pharmaceutical industry. We have a very comprehensive approach which basically starts with chemistry, understanding the production of these harmful chemicals that you find in cigarettes, and ensuring that we are producing none or significantly lower levels of them with our reduced risk products. We then go on to something which we call preclinical assessment, which has two main components. The first is standard toxicology, which are toxicological assays which are used by the pharmaceutical industry, for example, or similar to what is by the pharmaceutical industry. Just a word, because I said toxicological, I should really explain what toxicological means. So toxicological is essentially the amount of damage a chemical or a mixture of chemicals, and in our case, smoke or aerosol from RRPs, how much damage that causes to a biological system. And basically what we want to try and determine is that when you expose the biological system to the aerosol from a reduced risk product, you're not causing as much damage or very little damage compared to the damage you get with a conventional cigarette.
Okay.
So that's basically the toxicological or the preclinical part. We then do a number of clinical studies, and we do something called perception and behavioral assessment, which is basically understanding how people use their product, what do they like about the product, what don't they like about the product. Importantly, are we aiming the product at the right audience, which are current adult smokers who don't want to quit? And then finally, we do long-term studies with people when they switch to a reduced risk product to basically understand what is the health impact of them switching in the long term.
Okay. And could you give examples of the type of clinical studies that are conducted here at the Q?
Yeah, sure. So we do a lot of clinical studies, and broadly you can describe them as three main types.
Right.
Okay. So the first type is something called the pharmacokinetic or pharmacodynamic study, and essentially those studies are designed to see that when smokers switch to a reduced risk product, what is the level of nicotine that is being delivered to them.
Okay.
Now, one important point about the nicotine is that it really is important that we're delivering the same amount of nicotine, because that will help current adult smokers who don't want to quit to switch to the product. You know, we've seen in the past, you know, with things like nicotine replacement therapies and the early generation of e-cigarettes, where the nicotine delivery is not adequate, so not enough, not similar to what you get in a cigarette. People can't stick with them. And if people can't stick with what is essentially something that could potentially reduce the risk, then we're not going to have the impact on the population harm that we want to have. So essentially what we're trying to do is we're trying to deliver nicotine without the harmful chemicals, and the pharmacokinetic study tells us if we are able to deliver the same amount of nicotine as you get with a cigarette. The second type of clinical study we do is something called a reduced exposure study. And as I explained to you before, Ivan, when you burn a cigarette, you're producing over 7,000 chemicals, and as a smoker, you're inhaling those chemicals into your body. What we want to try and determine with our reduced exposure studies is that when someone switches to a reduced risk product, are they actually being exposed to less of those harmful chemicals? We can show from the chemistry that perhaps there is a reduction in the formation of those chemicals, but we then need to understand from a clinical perspective by looking at what we call biomarkers of exposure in the blood or the urine, breakdown products of those chemicals, to understand that when someone does switch to a reduced risk product, are they in fact being exposed to less harmful chemicals compared to smoking cigarettes.
Okay.
And then the final type of studies, clinical studies that we do, is essentially to try and understand the risk, if there is a reduction in risk. And these are longer term studies which last for 6 to 12 months. And again, we get smokers who don't want to quit smoking to switch to reduced risk products, and then we follow them over a 6 to 12 month period, and we look at a number of different parameters which will tell us about their health.
Is there a specific age for these subjects?
Yeah, sure. So basically, the requirement is that all the smokers need to be smoking for at least 5 years. So the minimum age is normally around 24, 25, and it goes up to basically what we get in terms of people smoking. I mean, I think, I don't know exactly, but I think the maximum age we probably have in our studies is something like 55 or 60. But essentially, they switch to these reduced risk products for, as I say, 6 to 12 months. And the idea is to see if there is a change in these biomarkers now, not of exposure, but biomarkers of risk. So things like cholesterol, high blood pressure, lung function, things which tell us how healthy a person is. And basically what we want to do is try and understand that when they switch to this reduced risk product, is there an improvement in their health compared to people who continue smoking and compared to people who quit smoking. And ideally what we would like to see is that an improvement in their health when they switch to ARPs is similar to the improvement we see with cessation, and very different from the lack of improvement or the worsening of disease you get when you continue smoking.
Okay. So then, can we yet determine whether switching to RRPs reduces the risk of smoking?
Yes, we can. We do it in two ways. We do it preclinically through something called systems toxicology. Now, systems toxicology uses really quite sophisticated scientific methods to try and understand what is the impact of an aerosol or cigarette smoke on biology. We look at the changes in gene expression, so understanding what is the genetic impact of exposure. We look at the protein levels, we look at lipid levels, and all of this gives an understanding about the biological mechanisms which switch on disease, and to understand if when people switch to a reduced risk product, is there a change in those biological mechanisms or not. Now, we do that preclinically in laboratory models, but at the end of the day, we need to understand what happens in people. So this is where we do our 6 to 12 month studies, where we then look to see if there's an improvement in health in people when they switch to reduced risk products.
Okay, so that's the science.
Yeah.
Excuse me. But RRPs can only reduce the harm of the cigarette smoking on the population as a whole. If people actually switch to these products.
Absolutely.
What work are you doing in this area?
So we're doing a number of things in this area. I mean, yes, it's important that people switch to the product, but equally important is to make sure that people who don't smoke don't start using reduced risk product because they think there's a reduced risk product on the market. It's really important that ex-smokers who have quit don't start using product again because they believe that there's a safer product out there, or a less risky product out there. And of course, we never want underage people to start using products. So we need to ensure that these are not the cases. And so we have a big program called Perception and Behavior Assessment, where essentially we use focus groups and we present to them the product, the communication material around the product, marketing material around the product, and we make sure that we are only reaching the target audience with our communications and portfolio of products. And of course that target audience is people who currently smoke and don't want to quit. So that's basically how we handle that. And it's actually something that regulatory bodies like the FDA recommend that is done for making reduced risk claims with products. So we do research with them and we do a lot of that.
Okay, and what about long-term assessment? Are you doing any work on what the long-term benefits or risks of RRPs might be?
Yeah, of course. Long-term assessment is really important because until now, everything we've described has been about risk. And it's really important to differentiate risk from harm. Okay. So by definition, risk of getting disease is the probability of you getting a disease if you switch to the product. We know that the probability of you getting a disease is very high when you smoke cigarettes, and what we want to basically ascertain through our research is that the probability of you getting a disease is significantly lower if you switch to a reduced risk product. But that's only risk, that's only probability of getting disease. What we ultimately want to show is that we have an impact on the harm that smoking causes to the population today, and harm is actually disease incidence. So we need to do long-term studies in order to understand that when people do switch to these reduced risk products, is there a reduction in the amount of disease or the amount of harm that's being caused? And yes, we are doing these studies. A great example is a study that we have done, study that we have started, I should say, in Japan. Japan was the first country in which we launched our first reduced risk product. And we've already started a 5 to 10 year study where people who have switched to the new RRP can decide to enroll in the study, and then we follow them for 5 to 10 years to understand what is their health outcome over a long period of time when they've switched to reduced risk products.
Thank you, Nveed. Thank you very much for answering my questions. We'd like to open the floor, as it were, to the viewers at home to see if you have any questions. Nveed, do we have a couple on the board over there?
Yeah,
if you'd like to take them?
Yeah, I'm just having a look. So we've got a really interesting question from Sophie, which is, what kind of background do scientists at the Cube have? Well, as I said at the beginning, Sophie, we have over 450 scientists and engineers working in the Cube. And if you look at the total number of disciplines that are represented, we have something like 39 different disciplines represented, and actually 30 different nationalities. So it really is a very global science workforce that we have here within the Cube. We have people who have backgrounds in toxicology, in chemistry, in biology. Myself, I have a background in pharmacology and respiratory medicine. People in my team have backgrounds in communications. We can have people who have backgrounds in material science. So really, what we understood 4 to 5 years ago when we really ramped up our R&D capabilities and really started to look at how can we find solutions for the issue of tobacco-related disease. We understood that in order to be able to do this, we need to look at this from a wide range of scientific disciplines and wide range of scientific angles. And for that reason, we have a very large sort of skill set and background of scientists within the Cube. So in a nutshell, if you have a scientific background which has trained you in doing robust science, in publishing science and being proud about the science that you're doing, your discipline is probably represented here in R&D.
Okay, we'd like to invite another question. We've got a question from James in England.
My home country. Yeah.
Whereabouts in England?
Well, originally from London, but more recently Southampton.
Southampton,
yeah.
Okay, just on the coast.
Oh, yeah.
James is asking, do you offer fellowship or internships here within PMI Sciences?
Yeah, in fact, James, what you will see if you go to pmiscience.com is a fellowship program that we launched only about 3 or 4 months now. And essentially every year we will have different fellowship programs around different aspects of the science that we're conducting that you can apply for, and we encourage everyone to apply because you have the opportunity to have a very international and exciting career within PMI Science, and it's there on the website, pmiscience.com.
We'd like to...
we have a follow-up from James.
James has asked another question.
Okay.
James is very interested. Thank you, James, for your interest.
Research grants.
Research
Yeah.
grants.
Okay, so what we have launched about 7 months ago now is something called investigator-initiated studies. Again, if you go to pmiscience.com, you'll be able to find the link on the website there. Essentially, what we recognize is that there's going to be a lot of interest from the external academic community to try and understand reduced-risk products for themselves. And essentially what we have is this program in place where you can apply for help from us, technical help or funding help or anything that you like basically in order to be able to do these studies. And the idea is that it then goes through a decision committee. If the committee decides it's a program that is interesting for us, you then get the support that you asked for, and you independently then conduct the study, publish the results yourself with no interference from us at all. The idea is to try and get as many external scientists to research reduced risk products and our reduced risk products so that we can get independent understanding of what you find by doing these types of studies.
Okay, questions flying in here. We'll try and get you all in. We've got a question from Nikki in Lausanne,
yeah.
not too far from here at the Cube.
No.
And Nikki has asked, why is the work at the Cube so important?
That's a great question, Nikki. I think we can answer it in the following way. So, as Philip Morris International, we are the leaders in the tobacco industry. We are the largest tobacco company out there. And we have a large R&D capability which is allowing us to develop these new products. Technology over the last 4 to 5 years has really allowed us to accelerate the development of these products, assess these products, and then eventually commercialize these products. The impact that we can have on public health is massive. If we can get every one of our consumers, people that smoke cigarettes, and other consumers as well of cigarettes, to switch to a reduced risk product, what we will ultimately hopefully be able to show is that if you do switch to these products, you are going to have a reduction in risk and then eventually a reduction in harm. We can have a massive impact on public health. It really is an impact that you cannot have in any other industry at all. Of course, within the pharmaceutical industry, I have a background in the pharmaceutical industry. You do have impact on people's health through the through the discovery and then manufacturing and commercialization of new drugs. But that's normally just in 1 or 2 disease areas. But what we can do is have a massive impact on people who suffer from COPD, or are likely to get COPD in the future, people who are likely to get lung cancer in the future, people who are likely to get cardiovascular disease in the future. We can have a positive impact if we can get all those 1.1 billion smokers that the WHO predict there will be by 2030 to switch to a reduced risk product. The public health impact we can have is absolutely massive, and that's what motivates me to come to work every day and motivates us here at R&D to do the research that we're doing.
Okay.
Then we have one final question. Sorry to interrupt you, Ivan.
We've got a question from Philip in Italy. Thank you, Philip. And he's asked, why should we believe the results from PMI? Why should we believe the results from PMI Science?
Yeah, no.
Generally speaking,
it's a very legitimate question, Philip. Thank you very much for the question. Look, we understand that there's going to be skepticism from data coming from us being the tobacco industry. What we have tried to do and what we are actively doing is being as transparent as we possibly can about the data that we are collecting, the interpretations we are making from that data. For example, since 2010, we've had over 150 peer-reviewed publications. Now, just to explain a little bit about what peer review actually means. Peer review means that when you want to publish a scientific data set, it actually, you submit it to a journal, and the journal has the data and the interpretations of that data independently verified by 3 anonymous reviewers, normally at least 3. Only if those anonymous reviewers agree that the results are novel and that the methodology was robust and that the conclusions from the results are true, is the paper allowed to be published. And as I say, since 2010 we've published over 150 papers in these peer-reviewed journals. We present at conferences, we present at scientific conferences, we present at public health conferences. Really, we're trying to put our data out there as much as we possibly can. Last year, we launched PMIScience.com, where we basically talk about our approach in a very transparent way. We publish our latest publications and data on the website. I mentioned, Ivan, to you earlier that we do a number of clinical studies. All the clinical studies that we do are published on a website which is governed by the National Institute of Health in the US called clinicaltrials.gov. And essentially, the way in which clinicaltrials.gov works is this. When you have the idea to do a study, you submit the study protocol to the website. Everyone can see that you're planning to do this study. And then you conduct the study. And by publishing the study up front on the website, you're making a commitment to then publishing the data of that study on the same website, regardless of whether the data is the way that we want it to go or not. And so all our clinical studies are registered on clinicaltrials.gov. So I think, I understand, of course, the skepticism. We're trying to address that skepticism by being as transparent about the results as we possibly can. And we are always open for discussion and interpretation of our results, and we welcome lively debate.
Okay. Guys, thank you very much for joining us today. That's all the time we have for now. We encourage you to, if you do have any more questions, we're happy to answer these after the session. In the meantime, we'd love you to follow us at PMIScience.com to join in the global conversation. We really do encourage many questions. We're happy to answer, and we look forward to continuing this conversation with you guys in the future. Thank you very much for joining.
And happy World Science Day.
Happy World Science Day.